Hello students, I hope you're doing okay. We're going to have a set of 3 voiceover PowerPoints for this section. One on antiplatelets and one on anticoagulants and another one continuation of anticoagulants and fibrinolytic drugs. As usual, my reference is the pharmacology book, which is Goodman and Gilman. And I also put on Moodle a medical letter for thrombosis. This is for your information, not for your memory, but if you are interested. You've already taken, I believe, a session on the coagulation cascade, another one on platelet activation. So what would wonder why in the circulation we don't have coagulation and platelet aggregation? Well, it turns out that when we have a normal or an intact vessel, meaning that there is no vessel injury, the coagulation factor would circulate in inactive form. You already know by now that, for instance, when you have tissue injury, you would have loss of the endothelium and hence the exposure of the subendothelial tissue, and then this would trigger platelet activation. You also have the release of the tissue factor and the coagulation cascade. Well, if we have an intact vessel, this will not happen. This is one. Two, I just mentioned that the endothelium that is covering the subendothelial tissue is devoid of thrombogenic tissue factor, collagen, and hence this prevents platelet activation. Also, the maintenance of the brisk flow through the blood vessels ensure that any activated coagulation factor is whisked, it's taken right away to the liver for degradation. This is why a brisk blood flow is important, and this is something that we lose, for instance, in venous diseases when we have stagnation and hence venous thrombosis. So the flow of the blood is very important for that as well. What is the definition of hemostasis? By the way, you're going to see some repetition in my slides, but it's okay. I think repetition is fine. I'm sure this was already described for you. Hemostasis is a physiologic process by which bleeding is stopped. When we think of hemostasis, we want to think of two phenomena happening together. One, we have the formation of the platelet plug, and two, we have the coagulation cascade that ultimately leads to fibrin that reinforces this platelet plug. And if you look at the electron microscopy picture here, you can see red blood cells actually, and then those lines are the fibrins, and some dots at the corners of the lines, those are the platelets. You've seen this slide before. I've borrowed it from Dr. Tamraz and I added a few things. Well, we already said that we start with the vessel injury, and that would lead to several events, ultimately leading to a stable hemostatic plug. One thing that could happen, we have exposure of the tissue factor, and this will lead to blood coagulation cascade, ultimately leading to thrombin and fibrin, which would attach the platelets together. It's important to realize that everything is interrelated. For instance, thrombin or factor 2A is involved in platelet release and platelet aggregation as well. At the same time, vessel injury will lead to platelet adherence and activation. Why is this happening? The adherence is happening because of the adherence of the platelet to collagen, as well as attaching through von Willebrand factor. And this leads to activation and hence release of certain factors such as serotonin and ADP, and synthesis of other factors such as thromboxane A2. And ultimately leading to platelet aggregation, the primary hemostatic plug, and ultimately the stable hemostatic plug. And one of the things that stabilizes the hemostatic plug, in addition to fibrin attaching all platelets together, is also the reduced blood flow because of vasoconstriction. How is vasoconstriction happening? There are several mechanisms. One of them is the neurogenic reflex happening right away from vessel injury, but also from factors released from the platelets such as serotonin, ADP, and thromboxane A2 that is synthesized in the activated platelet. In this slide, the writing that is in black is has just been explained, and only what is in red is something new. So we agreed how vascular injury leads to platelet aggregation, the coagulation cascade, ultimately ending up with hemostasis. But also, this cannot go on forever. This has to be removed at some point. So the coagulation cascade must be restricted. And how does this happen? It can happen at the local site where we have termination of clotting by antithrombotic control mechanisms, and we will talk about that next time when we talk about heparin as an anticoagulant. And also, if coagulation has stopped, we also want to get rid of this plug. We want to lyse it, so the clot is finally removed by fibrolysis. There's an important principle that I'd like to explain here. Now, when we have a hemostatic plug, in this case, or a thrombus, in this case, we would have both platelets and fibrin, of course. But there's a difference between arterial thrombi and venous thrombi. Arterial thrombi mainly consist of platelet aggregates held together by a small amount of fibrin, whereas venous thrombi are composed mainly of fibrin and trapped red blood cells. Why is this important? This is important if you want to think of prevention. For example, you probably know that if we have a patient who is at high risk of developing coronary artery disease, this patient does not have an MI yet, but he's at high risk. He's male, he's 60-year-old, he has diabetes, hypertension, obese. So there's a reason to prevent arterial disease, and you would give in this case an antiplatelet. You would not give an anticoagulant. Why? Because arterial thrombi again consists mainly of platelet aggregates. Whereas if you are dealing with a patient who is at high risk of venous thrombus, for example, we have a pregnant woman who had a thrombus before and now she's pregnant, she has venous stagnation, she has a high risk of recurrence of her DVT, deep vein thrombosis. And if we decide to give her prophylaxis or prevention of another venous thrombus, in this case it would be an anticoagulant that inhibits the coagulation cascade rather than platelet aggregation. Now, but let us not be confused and think that anything arterial is only antiplatelet and anything venous is only antithrombotic. For instance, if you have a patient coming to the emergency room with myocardial infarction, MI, which is a thrombus in the coronaries, well, in this case, we want to give both. We do give antiplatelets and we do give anticoagulants. And guess what? We also may give fibrinolytic drugs, drugs that dissolve the thrombus. Now, it really depends on the presentation. But for prevention, usually we tend to differentiate, although again, sometimes even for prevention, we may give a combination of antiplatelet and anticoagulant. Maybe the patient is having recurrent attacks, or maybe whatever. It really depends on the clinical scenario that you will learn later in your clinical years. So now for the outline. In this voiceover PowerPoint, we will discuss platelet adhesion and aggregation. We will review them, and then we will go over the antiplatelet drugs. We have aspirin as COX-1 inhibitors. We have inhibitors of adenosine uptake. We have P2Y12 ADP receptors inhibitors, those that are irreversible and those that are reversible. We have the PAR1 blockers, and finally we have inhibitors of the glycoprotein 2B3A. And then next we will talk about the anticoagulants. We will start with the review of the coagulation cascade and discuss the coagulation test. When do we do a PT and when do we do a PTT, and why are they different? We'll talk about the control and termination of the coagulation process, and hence we would understand the mechanism of action of the anticoagulants. We will start with the parenteral anticoagulants, the antithrombin 3 activators. We have the indirect thrombin inhibitors and the anti-10A, and then we'll move to the oral anticoagulants. We do have the direct oral anticoagulants, the DOACs, and then finally with the vitamin K antagonists. And then towards the end, we'll talk about the fibrinolytic drugs. They are the only drugs that can dissolve a thrombus, and those are plasminogen activators. So that slide set the stage for you to always remember that all the drugs we are discussing here, being antiplatelets, anticoagulants, or fibrinolytic drugs, they are associated with bleeding, and this being an extension of their therapeutic effects. Finally, we're going to talk about platelets and antiplatelet drugs. Your book, The Goodman and Gilman Pharmacology Basis of Therapeutics, has very nice online movies on antiplatelet drugs. It also has nice movies on coagulation, anticoagulants being oral or parenteral, and also has about fibrinolytic drugs. I highly recommend that you watch them. They are very useful. I found them useful to me. I'm not sure if you can access them from home. Maybe you have to use your AUB password. Now, if you click on the movie and you don't reach it right away, you may reach a site that says I'm not sure exactly. On that site you will find a place button for multimedia. Hit on multimedia, and after multimedia hit on pharmacology, and you will find all the pharmacology movies over there. I really highly recommend that you watch those. In this figure, we have a summary of platelet adhesion and aggregation. Not every single factor is shown in this figure. What is shown is what is important to us from a therapeutic point of view. So again, we start with tissue injury, and hence we have exposure of collagen. We also have von Willebrand factor that comes and attaches to the subendothelial tissue, and this leads to adhesion of the platelets through collagen and von Willebrand factor. Collagen on the GP1A2A receptors and von Willebrand factor on the GP1B. Well, this leads to release of factors, secretions of factors from the platelets, such as ADP, among others. And also we have activation of enzymes such as COX-1 to release thromboxane A2. And this will lead to activation of the platelets. What do we mean by activation of the platelets? Meaning that the GP2B3A receptor becomes active to receive fibrinogen. Of course, you already know that fibrinogen needs to be stabilized into fibrin, and hence once you have fibrin on the GP2B3A receptors, you would have a very nice stable plug with platelets and fibrin. So those factors are important. I borrowed this slide from Dr. Tamraz to remind ourselves that von Willebrand factor is important not only for adhesion by binding to the subendothelial tissue and to the GP1B receptor on the platelet, but also it has a role in aggregation by binding to GP2B3A receptor. So what are the drugs that we're going to discuss? What is their site of action? We will start with aspirin as an inhibitor of COX-1. I believe you already took non-steroidal anti-inflammatory drugs that inhibit both COX-1 and COX-2, and aspirin actually can inhibit both COX-1 and COX-2, but in the dose that we give here as an antiplatelet, as a low dose, it inhibits COX-1. Also we have dipyridamole for ADP, and we have ADP receptor blockers, the PY12 receptors, and we have a bunch of drugs that irreversibly block that receptor, and ticagrelol as a reversible. We have voraxapar that inhibits the binding of thrombin to PAR1 receptor, and finally apiximab, epitifibatide, and tirofibam that inhibit that antagonize the GP2B3A receptor. Let's start with aspirin as a COX-1 inhibitor. Again, I just said that it inhibits both COX-2 and COX-1. And what do we want to inhibit in this case? We definitely want to inhibit COX-1 because we want to prevent synthesis of thromboxane A2, because thromboxane A2 leads to platelet activation and vasoconstriction, and we don't want to do that. And how does aspirin only work on COX-1? It works by giving a low dose, and that dose is 81 to 325 milligrams per day. When you give the anti-inflammatory dose of aspirin that inhibits both COX receptor, well, the dose is about 325 milligrams milligrams, 2 tablets every 6 hours. So it's a much higher dose. And this is low dose is what we call baby aspirin. So as baby aspirin is really not aspirin for babies, it's just that it is a low dose aspirin as an antiplatelet. So what do we know about it? It's very important to realize that it irreversibly blocks COX-1, and it does that by acetylating a serine residue near the active site of COX-1. And being an irreversible blocker and knowing that the platelet's life lasts for 7 to 10 days, that means that there's a high risk of bleeding for 7 to 10 days as long as aspirin is on. And you may have heard of scenarios like that. For example, if you have a patient taking aspirin and that patient needs to do some kind of elective surgery meaning that they decide now to go and remove the gallbladder. There is no emergency. The gallbladder is not infective. There is no need to remove it right now. If we can wait and if we can afford to stop the aspirin for 7 to 10 days, that would be better because you would decrease the risk of bleeding. Another thing that we could do, we could prepare red blood cells just in case the patient bleeds. We give packed red blood cells. So this irreversible is very important. Again, we talked about the dose being a low dose, and at higher doses it would also inhibit prostacyclin production in the vessel endothelium that must be spared. I will not go back in the voice over PowerPoint, but I want you to go back and look at slide number 15, where there is towards the right there is prostacyclin that is released from the endothelium, and that inhibits black platelet aggregation, and we definitely do not want to do that. Next, we're done with aspirin. Now we talk about dipyridamole, and it blocks platelet uptake of adenosine. We don't really use it much. It's because we have now other antiplatelets that are much better. We have aspirin as an old one, and we have clopidogrel and the others. And also, it is not only an antiplatelet, it's also a vasodilator. How does it do that? By blocking phosphodiesterase PDE enzyme. You're going to see this with me next year when we talk about asthma and the mechanism of blockage of PDE enzyme. But we have several drugs that are also vasodilators through blocking phosphodiesterase enzymes, such as Viagra. In this case, that is leads to vasodilation in an area that is important. Next are the P2Y12 inhibitors that inhibit binding of ADP and hence activation of the platelets. We have the irreversible blockers, and that is ticlopidine, clopidogrel, and prasugrel. Ticlopidine is the first one that came to the market, but it's now almost obsolete. We don't have it. I don't think we use it at all. Why? Because it is associated with life-threatening blood dyscrasia and high rate of thrombocytopenic purpura. So at the time when we used to give it, we had to do CBC platelets on the patients like every week because that was a major problem. Now we don't use ticlopidine anymore. So now we use clopidogrel. What is clopidogrel? Same mechanism. It inhibits irreversibly the P2Y12 receptor on the platelets. And because of the irreversible binding, you would expect the same thing like aspirin. So it would require stoppage of the drug if we anticipate the surgery, if the surgery is elective for 7 to 10 days. In contrast to ticlopidine, it has a favorable toxicity profile. But the problem is that it is a prodrug that is activated by CYP2C9. Why is that a problem? Well, this is a problem because you may have clopidogrel resistance in people who are CYP2C19 poor metabolizers. For instance, you may have a patient who has coronary artery disease who undergoes an angioplasty or a balloon or a stent, and as we said, this leads to vessel injury, and because of the vessel injury you want to give an antiplatelet for a while so that you don't have recurrence or you don't have a thrombus, right? Well, so one of the things that we could do is give clopidogrel 6 months, 1 year, it really depends on the scenario, and the patient may come back with a thrombus, and we call that clopidogrel resistance. Why is the case? many potential reasons. One of them, our patient could be a CYP2C19 poor metabolizer. Another thing that could happen is a patient may be taking a proton pump inhibitor, and as a matter of fact, we discussed that antiplatelets, including clopidogrel, are associated with bleeding. So physicians may give clopidogrel in a combination of a PPI in order to decrease acidity in the stomach so that the patient does not have a bleeding from a gastric ulcer, for example. And it's not a good idea to give omeprazole or esomeprazole because both of them inhibit CYP2C19. So now we know that if you want to give a PPI with clopidogrel, it's better be something else, such as prasugrel. What are indications for clopidogrel? Well, one, it can be given together with another antiplatelets. For example, we can give it with aspirin, and here you have the synergism. Again, after a percutaneous coronary intervention, but you can also give it for several other scenarios in combination, alone. Duration differs depending on the scenario, whether we want to reduce the rate of stroke, MI, death, peripheral artery disease, etc. Now, we also have another irreversible P2Y12 receptor inhibitor, and that is prasugrel. Prasugrel, it has a greater and more predictable inhibition of the platelet aggregation. We were very excited, but it is not associated with CYP2C19 interaction. However, it has more bleeding risk, and hence it is contraindicated in patients with prior history of stroke or TIA, because those patients may bleed, and if they bleed, it's a problem. And also in patients who are elderly or those who are underweight, they are also at a higher risk of bleeding. Finally, for the P2Y12 inhibitors, we have ticagrelol. In this case, it is a reversible binding to the P2Y12 receptor on platelets. And in one of the trials, among others that came later, this is a relatively old trial, well, it turns out that the combination of ticagrelol plus aspirin may be more effective than clopidogrel plus aspirin in preventing cardiovascular deaths. However, we had here a major bleeding and fatal intracranial bleeding. This is not for your memory really, but what I'm trying to say is that we have several options, and the question is, which one do we choose? It really depends on the available data. It depends on the patient that we have. Next are the PAR1 antagonists, and in this case we talk about voraxapar. We already know what it does. It inhibits thrombin-induced platelet aggregation, inhibits the binding of thrombin to PAR1. Also, not for your memory, but again, we can give it with aspirin, we can give it with clopidogrel to reduce cardiovascular events. We give it in PAD, patients who have a history of MI. So we're talking prevention here in arterial disease, but also it is associated with a higher bleeding risk, and hence it is again contraindicated in patients with prior history of stroke or TIA. We don't want those patients to bleed in their brain. That would be really problematic. Finally, we want to talk about the glycoprotein 2B3A receptor antagonist. Well, all the drugs that we talked about, the antiplatelets, are given orally, whereas this set of drugs, they're given IV. They are very potent. They are given in the hospital. We already know what they do. They prevent platelet aggregation by competing with fibrinogen and von Willebrand factor. We already discussed that von Willebrand factor also binds to GP2B3A receptor. Those are indicated in the hospital during PCI for percutaneous coronary intervention, and if a patient is admitted presents with acute coronary syndrome such as unstable angina or MI. You would learn those in cardiology. We have several drugs on the market. We have apixaban, eptifibatide, and tirofiban. They are a little bit different, but they're all GP2B3A receptor antagonists. And the most important thing to remember is that, again, there's a high risk of bleeding, but also bleeding can happen at arterial access sites. we just discussed that those drugs are given in the hospital. You can give it for a patient who's admitted for a PCI, and in order for you to do the PCI, you really need an arterial access. You get the catheter inside the artery, whether it is in the radial artery, usually I believe in the radial artery. So you already have an arterial access that is difficult to close, and you may have bleeding at that site as well. This is why when the patient is done, the patient has to rest the hand or the leg, depending on where the arterial access is done, for a couple of hours so that you don't have bleeding. Another thing, you may produce profound acute thrombocytopenia, and that could be problematic, especially with apixaban. I think we're done in this one, and we'll do next.